AATS Mitral Conclave 2015. It's been an interesting day. I'm thrilled to be joined by Dr. Craig Miller. Craig is known to all of you, I'm sure. Craig, you were president of the AATS in 2008?
2008, right.
Been a fabulous cardiac surgeon at Stanford for years, and thanks so much for joining us. So
that's where we met, when you were an Echo fellow some 30 years ago.
It's 30 years ago. My Lord, what's happened over those years? So I'm going to start out with a simple question. How do we regulate, that's a bad word, how do we assure quality in mitral valve surgery over the years? I mean, it's a tough deal since quality is now, not quantity, but quality is now the new outcome marker.
Quality is the most important thing we should talk about.
Absolutely.
Unfortunately, you've touched on a radioactive question, which I nor any politician would touch. So I've got to dance around it, talk about some other topic, but I won't, Randy, because I think it's so important.
Right.
None of us, including the world's authorities here today and tomorrow, can tell you or the audience we're any good or not until we have external audited results.
Interesting.
And in the UK, they've tried this. It actually filtered across the English Channel into Europe. But unfortunately, I learned last month in the UK, the Ben Bridgewater plan and a single-payer system, which was going to set requirements for a surgeon in a center, 25 mitral repairs a year, 50 mitral repairs a year per surgeon, 50 for the institution. And everybody had to submit 1-year and 5-year echoes to an external core lab.
Interesting.
Or you wouldn't get paid. And that was 2007, I think, 6. Unfortunately, it has failed to gain traction, and it depends on which NHS trust you belong to, and there's just too much ego and probably too much money involved, and it has failed to take off. So until we get that sort of airplane off the runway, none of us can talk about quality.
That sounds fabulous. So you have independent auditing, and you look at echo results. So that's the easiest way to look at how the patient's doing. Is that? I mean, it sounds like it's a great deal, but it sounds like if it's problematic there, it'd be really problematic here. You know, who are the external auditors, et cetera, et cetera.
With a single-payer system, it might fly, but unfortunately, it hasn't. Here, it's probably impossible, but I think we have to strive. Rick Nishimura today said the Guidelines Committee feels it's up to the societies, the ACC, AATS, STS, and we have to fund it, and we have to police it, just like the TVT registry for TAVR. But it's going to not happen tomorrow. But I think we have to try and make it happen. And only then will we know how many mitral valve operations, repair or replacement a year, is a reasonable threshold to get quality.
And I think having people, and I know you've done this, and David Adams' group has done this, where you report on, and Tyrone obviously, report on your results, report on your in the peer-reviewed literature, and say, look, this is my 10-year result, or you've got to have obviously honesty in reporting, and report your results out, and you've also got to have experience, don't you? I mean, in doing a lot of cases.
You do, but the single center results, and by the way, only one has a relatively recent echo, and that's Tyrone David's Toronto General Hospital. No one else has late echoes. We're kidding ourselves to think we really know what our results are, as you as a cardiologist will say. But it's very expensive, and it's tough, and how do you enforce honesty? It has to be external. And one of the problems with surgical reporting in general, like STS we're so proud of, we learned so much of, it's totally voluntary, subjective, and biased. And if you're talking about bad things like strokes, and it's going to be an underestimate.
Yeah, but in the UK, they were tying it to payment.
Reimbursement.
So money talks.
Right.
You think we'll ever get to that in this country?
We have to.
Yeah, I agree with you.
The average U.S. surgeon for the 2 years of Steve Bowling's survey, excluding 400 surgeons who didn't do one mitral procedure in 2 years, only did 5 a year, repair or replacement. And then we think we're a success to see the percent of valves repaired go from 30 to 50 to maybe 60 until we read the Medicare report, which just came out again for 10 years. Medicare beneficiaries over 65 60-70% of getting valve replacement. Now, I'm not sure that's wrong. I'm not sure it's good.
Right.
But at least we have the big denominator. David Adams wrote the editorial and said it's a megaphone effect because you have so many tens of thousands, hundreds of thousands of operations. Big data speaks, but the Medicare database is not designed to do clinical research from. It's for billing and accounting, and we don't know the etiology, we don't know the mechanism, we don't know what was done. It's just a global 40,000-foot overview. But it's scary when you look at real-world results like that compared to these centers of excellence, which you mentioned. But I must give credit to Tyrone David, 15, 20 years, a lifetime of work in mitral repair.
Yeah.
Almost 98% complete late echo.
Yeah, no, it's phenomenal.
Phenomenal.
I mean, and obviously, it was interesting because I visited with Tyrone earlier, and I asked, are we going to see this again? And you've done the same thing. You've been an excellent aortic surgeon and an excellent mitral surgeon. Are we going to see that model again? Are we going to see a surgeon today who's going to be excellent in the aortic space and in the mitral space? I think it's going to be difficult.
Well, I think it's coming. I wrote an editorial in your journal, Jack. I said another meiosis in the field of cardiovascular surgery. We've sprung off a different bud, and it's going to be the purebred thoracic aortic surgeon. And I think eventually it will be a mitral surgeon, a thoracic aortic surgeon, but not both.
That's what I'm asking.
Yeah.
I mean, I clearly think there's going to be specialization, so you'll be a mitral surgeon or an aortic surgeon, but I don't think, what I was saying, you and Tyrone are a few of the guys who've done excellence in both spaces. I think that's going to be hard to reproduce in the years to come.
It probably will be.
Okay. Let me ask you something.
But Tyrone claims it's easier to do in a socialized system to get those annual echoes. And now we know that Medicare doesn't pay for an annual echo after a year if there are no symptoms. Will it ever happen?
You're never going to have.
It's unlikely, but we shouldn't let that deter us from trying.
Well, no, I'm not really talking about the echo outcome as much as I'm talking about acquiring expertise and excellence as a surgeon in that space, in those spaces. I mean, you've done aortic, you've done mitral well.
Yeah.
Tyrone is. I just don't see that model. I mean, I think it's going to be specialization.
I think you're right. It'll be little niches within our specialty, but that's probably better for the patients. You're going to have a minimally invasive robotic surgeon.
I think you're
You're
right.
going to have a valve surgeon, a thoracic aortic surgeon.
Let's end up with something simple, the mitral annulus. What's happening with the mitral annulus?
Well, they gave me the simple topic this morning.
I saw it.
I first had to explain to them the normal mitral annulus is ephemeral. It's nothing. It's a few little wisps of collagen. But most surgeons think of it as
I think of it as like a bunch of Q-tips bent around.
Yeah, but we think of it as a latigo on a saddle when you're saddling a horse, and it's really not. It does get thick and fibrotic in certain disease states, myxomatous valve disease, Barlow's, rheumatic. So we think it's strong stuff, but it's really not. And so what you do to the annulus depends entirely on the disease you're treating. And here where enlightenment is coming, slowly. We're no longer talking about mitral valve prolapse, which was so ignorant. We're talking about the old people with fibroelastic deficiency and a couple cords popped at P2 versus the younger people with Barlow's.
Right.
Both of them are primary MR, degenerative MR, but they're totally different animals. Their natural history is different. They certainly have to be treated different surgically, but at least enlightenment is coming slowly.
And do they require a different annular approach too?
Yeah, they certainly do.
Yeah, that's what you said
And
this morning.
different
And then
techniques.
secondary MR is a whole nother animal.
Totally different kettle of fish, and they're different kinds of rings, rigid rings, complete rings, but we as surgeons, and I think there's a growing awareness, have missed the boat. We're stopping at the annulus when the real problem is the ventricle, and now there's some really neat adjuncts to our small, complete, rigid ring, including sewing the papillary muscles together and putting a harpoon through the ventricle, the coapsis device. Interestingly, the Restore MV study, coapsis plus off-pump bypass versus surgical repair plus on-pump bypass, it was a better correction of the mitral regurgitation with a surgical repair, but there was a survival advantage to the coapsis, the ventricular reshaping.
Working on the ventricle.
So we're probably missing the boat surgically. And now we have MitraClip, the COAP trial, and the Reshape trial in Europe. Unfortunately, the Reshape trial was just terminated prematurely due to low patient accrual.
Right.
That's probably going to help these patients more than us putting any kind of small rigid ring in the annulus, even if we do sew the papillary muscles together.
Interesting. So, but I mean, you've done some really fascinating work on the mitral annulus and that all. And I thought your talk this morning was really excellent. Let me ask you: we see a lot of people now with mitral annular calcification. In fact, extensive disease, which becomes problematic, and we're beginning to see there'll be some cases presented here where people are actually putting in percutaneous valves into the
sapien valves, native mitral annulus.
I mean, is what's the disease process with extensive MAC? I mean, I see it obviously in renal dialysis patients, but we're seeing a lot of it.
That's because people are getting older and older and older. And you'll notice in the IFU for the MitraClip, it wasn't one of the indications. That's Everest 2, prolapse, primary MR.
Right.
And the Abbott eval probably didn't want to test the MitraClip and those worn out old calcified valves either. His results aren't going to be so hot. So what do we do? Today with commercial MitraClip, we have a dilemma. It's not in the NCD.
Right.
And how far are you going to push the envelope to violate the NCD? And what are the results going to be? You're lucky in some of these old people to find enough non-calcified leaflet to clip.
Right.
And they do have MR. So this innovative, crazy idea of throwing a sapien in a terribly calcified native mitral valve today makes some sense, and hopefully within a few years we'll have a transcatheter prosthesis for transcatheter mitral valve replacement, which will really help. Because the coapsis there, the MitraClip for prolapse isn't such a great repair compared to the surgical standard, and it's probably going to be good enough for the functionals with heart failure.
Right.
But for these old, worn-out calcified valves,
it's very tough.
We're probably kidding ourselves.
I mean, it's an interesting problem because, I mean, as I said, we see a lot. I mean, echo-wise, I see a lot of it with these incredibly calcified annuluses, valves. It's all the way up on the left atrial wall.
It used to be just the posterior annulus, the horseshoe of death, and now it's the anterior leaflet all the way around.
It's everywhere. I know. Well, listen, I appreciate you, and I know I gave you some tough questions, but you have been a beacon arguing for quality a long time, and I know your colleagues appreciate it, and I appreciate all that you've done to educate us.
And patients will benefit.
Patients will benefit. Thanks very much, Craig.
Thanks, Randy.
Good to see you. Thanks.